Greetings and welcome to our community discussion today. Please fill the seats on the aisles. Please fill the seats on the aisles in the front so that latecomers have a place to sit and back. My name is Jonathan Glauser. I'm the coordinator for today's discussion. Today's discussion is entitled My Own Death, Choices, Ethics, and New Approaches. We are pleased to have a panel of three distinguished speakers. In not particular order, but I think Mary Jo will open, so I'll start with her. Dr. Mary Jo Prince Paul is an associate professor at the Francis Payne Bolton School of Nursing at Case Western Reserve University. She's a fellow of Hospice and Palliative Care Nursing and a board-certified Hospice and Palliative Care Advanced Practice Registered Nurse. She's worked with patients with serious illnesses and their families for over 20 years. Dr. Prince Paul is a nationally recognized expert in hospice and palliative care nursing. She will be actually opening up the discussion. So in no other particular order, I will introduce Dr. Stuart Younger is Professor of Bioethics and Psychiatry in the Department of Bioethics at Case Western Reserve University. His primary research interests are issues at the end of life care. He's asked that I keep his introduction brief, so I'm going to stop there. Lisa Vigil-Schattinger is originally from Oregon, but has lived in Northeast Ohio for over 20 years. She has a master's in nursing from the Francis Payne Bolton School of Nursing at Case Western Reserve University. Her personal experience, she originally hails, she's dealt with Oregon's Death with Dignity law and end-of-life issues with her stepfather. She has formed a nonprofit organization, Ohio End-of-Life Options, and I believe that Mary Jo wants to start the discussion. So you're on, Mary Jo.
Well, good morning to all of you. Thank you, and thank you for having us this morning. This is a really important conversation, and the only way that we can begin to do this is to get together collectively like this. And so we are just enormously grateful for you coming together with all the questions that you have. And I think that will be probably the most germane discussion that we can have today, is after we've given you what we believe is important, that you'll be able to offer us questions, and hopefully we'll be able to at least provide you with the answers to those, or the resources for you to be directed in a different way. So as most of you probably know, or maybe not, we have nearly 70 million Americans who are aging in this country. In fact, 70 million Americans over the age of 70 in a couple of years. Now, this is not just a discussion about the aging population. This is something that I've actually taken up at Case Western Reserve University, where it's a mandated class for all undergraduates coming into our university to begin this discussion about something that is universal to all of us. We're not going to get out of this world alive. All of us in this room will die. So whether you knew that or not, I guess you know it this morning. It's a revelation, isn't it? Yeah, but we don't talk about it. In fact, I can guarantee you that we talk more about what vacuum cleaner we're gonna buy, what car we're gonna buy, and we also look into every consumer report we can find in order to do that. However, when we're perhaps talking about death, or maybe it's an experience that one of our loved ones has had, that we typically shun that discussion, and in fact, we often stop it. And we say, oh my gosh, that's morbid, let's not talk about it, let's ignore it, in fact. So we do, we live in a very death-denying society. We have fear about it. It's not so much that we fear about death itself, we actually fear the dying process. We fear what's going to happen, the uncertainty that's involved in that. And unfortunately, we hardly ever integrate family into that conversation. and therefore we have no information sharing or shared decision making. So there really is a need for this public discussion, and what I hope to be able to do, along with the other two panelists who are here, is to make this a public discussion, and what I call flipping it upside down, normalizing it, and doing something called a demedicalization of it. This is really not a medicalized discussion. It is a natural discussion that we should be having with our families and our loved ones and our friends, our healthcare providers. Every time we have, holding some kind of, opportunity to have that, whether it's at a Thanksgiving table, Easter's coming up, these are really good times to have these discussions. So here's just some quick figures about what's happening in our country in terms of our society, and I think these are somewhat earth-shattering. So 82% of our public thinks that it's important to put their wishes into writing and to have that discussion. 23% of us have actually done that. Okay? And this comes from the Conversation Project, which I'm going to talk a little bit about, and I'd love to have a discussion with you afterwards about this. It's a very, very interesting program that's sweeping our country. 90% of people say talking with their loved ones about advanced care planning, and this is just a word that I'm going to actually try to normalize for you as well, is important. So 90% of us think it's important, but 27% of us have actually talked about it with people we care about. 60% of the people say making sure their family is not burdened by these tough decisions is extremely important. Yet 56% of us have not communicated their wishes about how they want to be taken care of at the end of their lives. And I often say at this point, it's not just talking about what's important at the end of our lives. It's about talking about what we value, what we believe in as we live our lives, because that's what's often translated at the end of our life. Does that make sense to you? So this is what we know about the concerns most of us have, and then what we know about the goals that we wish for. Most of us are concerned about dying in the fear of pain. I don't want to be in pain. I don't want to have, intractable suffering. And that encompasses all domains: physical, psychological, spiritual, emotional, and social. We don't want to have family conflict. We don't want to have financial burden. Most of us don't want invasive, painful treatments, especially if we've thought about it in our heads and not communicated that to anyone, like feeding tubes, being on a ventilator, having medical interventions that may not be meaningful to us in terms of living a meaningful life. Dependence on others, role changes. So what we once were that was important to us, we now have changed in terms of that role and function in our circle. And then also the elderly caring for the sick. What does that mean? The 90-year-old husband potentially taking care of a 90-year-old wife when all kinds of functional limitations might be going on. What we want. Most of us want to be cared for in our own home, however we define that. Most of us want to be comfortable, and we want to maintain or somewhat improve, if we can, our function, our quality of life, however that is defined, and our independence. And all three of those combined actually produce what's called dignity. So what is advanced care planning? Because we just talk about this and we throw this word around, and so we think, what is that? It's not just the formulation or operationalizing those documents called the advanced directives. This is about the conversation that takes place. It's about deciding what is important to you first, with whom you'll share that, and then actually at the end of this process, it's completing documents, written documents. It's about the care you would want to receive if you become unable to speak for yourself. These are decisions to make regardless of what you choose for your care. Some of us may want to push to the edge. What does that mean? When I ask my students, they say to me, Mary Jo, I want to die in the ICU with every medical intervention you can give me. Well, at 19, that might look great. So we have to talk about, well, what does that look like? What would that mean? When would you say no to things? When would you tell others that that's not what you want? And the decisions always are based on your personal values, even though they might not be concordant with your family's values and preferences. And again, we can think about them, but if we don't discuss them and if we don't get them in writing, it's very difficult for us as healthcare providers to not have a GPS. That GPS is that advanced directive for us. It's not the end-all be-all because this is not black and white, but it certainly gives us a guide to know how to help you and to honor what you want. So let's talk a little bit about misconceptions and then the realities. So this has been in the literature, it's been out in society. It's always interesting for me to go to parties and things or conferences and hear these things and I'm like, oh no, that's really not right. So talking about this stuff, if you will, is going to make everyone depressed and everyone's going to die tomorrow. So we actually have a great body of literature that we have been able to study where there's not higher rates of depression when provided with honest information. And what this requires is teaching our medical students and our nursing students and all social workers, our healthcare providers, and even you in the public, how to have language that is not only correct, but how to have language that is communicated in a way that is compassionate and honest. Talking about advanced care planning takes away hope. Mary Jo, if you go in there and tell that man that he's dying, he's going to die. And that would be correct, probably, but he's also going to lose hope. What we know is that patients who are given a poor prognosis are what I call delivering life-altering news, where there's no chance of cure. Actually, when people get that kind of information, they actually have some certainty, they actually have some control, and they're actually able to get their affairs in order in a different way than having not given that information. Talking about advanced care planning makes death come more quickly. So we know that this does not affect survival rates. We've had a landmark study that was done about 5 years ago where we know when we integrate palliative care early in the disease trajectory and we take care of these people over time, they actually do better and live longer. So that pretty much negated that. So very, very quickly, I want to talk about primarily these first two documents. And again, these are documents that are not the end-all be-all. Sometimes people will fill out some of it and not all of it, but it at least attempts to get the conversation going about what is important, what you value. So the living will, and this is the living will that is your words. These are your words, your preferences that you've written down that documents your wishes about medical care when you have 6 months or less of life to live. And let me just tell you that that in itself is problematic because we do a really bad job of prognosticating or determining when someone has 6 months or less to live. It's also operationalized, or if you will, goes into effect if someone is in a persistent vegetative state. And that's also something that doesn't happen very frequently. So here we already have this gap that's really tough. But this is your words. When you are unable to speak for yourself, this is a legal document that needs to stand. Unfortunately, in our healthcare system, it's often overlooked because of all the different types of conflict that happens. And I have to be honest about that, but it is a legal document that takes your words and puts it into writing when you're unable to speak. What I believe is probably most important is to have a healthcare agent, what we call a healthcare proxy or a durable power of attorney for healthcare. This is someone that you are appointing to speak for you when you can't. This is a person who is not maybe your best friend or your husband or your wife. This is someone who will honor what you have asked them to honor when you are unable to speak for yourself. I had a woman who I was caring for, and she designated her postman. She said, he's the one who has come to my door every day, and he's the one who asks me about how I am and what I care about. My family doesn't do that. So it was the postman, and he agreed to do that for her.
Wow.
So that's probably one of the most, that is the most important document, if you will. I'm not going to go over the do not resuscitate document. That would be a whole another conversation we would need to have. So I'm going to just skip over that. If you all want to talk to me about that later, we can. That's something that happens on the inside of the hospital, and or if you're in hospice care living at home, but it's not necessary that we have a DNR. So questions to ponder. Whom do you trust the most to make healthcare decisions on your behalf if you're unable to speak for yourself? And that person will only know that if you begin to have a conversation about what matters most in your life. Would you or would you not want efforts made to prolong your life if your brain were permanently injured? with no explanation of a meaningful recovery. And I highlight that because I really want to highlight that with my patients and families. When we talk about that and they say, yes, we want everything done, what is everything? And then if we do that, will that lead to what would be called a meaningful recovery? And only you know that as a living individual. So these are two helpful websites, and I've also brought the documents we make available to all of our patients at university hospitals. It's a universal document. You can get it off of thecaringinfo.org. This is the living will and the durable power of attorney for healthcare. If you actually want the documents, I have them with me. The Conversation Project, and I highly encourage you to take a look at this, is just a great plan of how to start this conversation. It gives you some feeding material, if you will, about when we sit down at the kitchen table, you can't just open it up and say, hey, John, I really don't want to live like that. But maybe it's about like, hey, did you hear about Bill who died last week? I really don't want to die that way. And having the other person say, well, what does that look like for you? So great conversation starters that exist in these two links, and one of them has the documents in it. Just remember, the living will and the durable power of attorney does not have to be notarized. It simply has to be signed by a person who's unrelated to you. You're the expert in this. You are. Not your physician directing your care. You're the one who should be able to talk to your physician or healthcare provider about what matters most in your life. And hopefully that provider will have concordance with you about that. Start their conversation once you've identified what's important. This isn't an event. It's a conversation that's a process, and it often takes time, so start it today. Thank you.
Can people hear me? Yeah. Just stay here. So, looking around the room, I'm going to make a couple generalizations.
Use the microphone.
Get a microphone.
Yeah.
I'm going to make a couple generalizations. One of them is that you're all interested in this, I can see, and that you're all, like me, getting up there in age.
Yeah.
And I've been studying and writing about this subject since I was in my 30s, and I have to say, in the last 5 years, it has a special meaning to me that it didn't have before, because I start thinking about myself. Of course, something could happen to you when you're 20, but the chances aren't that great that it will. But the chances of something happening to us is much greater. And probably, like me, many of you, things have happened to you. And we're probably, many of us, alive because there are medical interventions that didn't exist before that have helped us. They may have been very aggressive medical interventions, and they may have been new medicines that weren't there. And so we live in a culture where, in fact, there are ways to meaningfully extend your life. Extend it in a way that you're willing to put up with what it takes to do it, and you're very happy with the results that come after it. You'd say, yeah, I'm glad I'm alive. I'm glad I had this and that I'm alive. The problem is that as you get older, the chances of those interventions getting you something that you are happy with begin to diminish. They don't go away completely, but they begin to diminish. And so we become concerned about these issues, concerned that we're going to get too much, and we're going to die in ways that we feel are undignified, lonely, painful. You can name other adjectives. The problem is knowing, to use an analogy from the sport of boxing, of when to throw the towel in. You know, in a boxing match, the manager has the right to call the fight. And throwing the towel, I don't know if they still throw in the towel, but that's what they used to do. They'd throw a towel in, and the referee would stop the fight. So, the manager wants to win, but the manager also wants to have the fighter for the next fight and maybe even cares about the fighter. So at some point things aren't going well, and the manager has to decide, okay, now I'm going to have to throw in the towel. Adding everything up, it's time to throw in the towel. And that's not always an easy moment. Because as I said, we live in an environment where even at our age, there are many things that can be done to save our lives and make us go on in a way that we're very happy to go on with. And it's that decision of when enough is enough that's so important. And it's one that sometimes the decisions are easy. I mean, the choices are clear, but sometimes they're not clear. And sometimes it's a matter of probabilities. Well, this could work, but the chances are only X. And then is X enough? And how do you solve that problem? You solve it by talking with people that you trust, family members, and if there's a doctor that you trust, that's a good thing too, or a nurse that you trust. So I'm going to just give a couple pieces of advice, and then I'm going to stop. One piece of advice is if you enter a hospital, it's nice to have a proxy who can make decisions for you. But it's also nice, and if you can have that be the same person, somebody who's tough. Because these days, I hate to say this, you sort of need a bodyguard when you go in the hospital.
Oh, yeah.
Because when you go in the hospital, you're probably going to be taken care of by strangers who change every month, specialists, and you're going to see a lot of faces coming by the bed. There may be poor communication. I actually think hospitals, I don't mean to cause alarm, but hospitals are great places to avoid if you can do it. So having somebody who doesn't feel intimidated by the institution and doesn't feel intimidated by the staff and can provide a person who has continuity with the information and the decisions, because that might not be provided by the hospital, is very, very important. So that's one piece of advice that, you really have to figure out who it is, because if you have somebody who's timid, that's not who you need. You need somebody who's going to ask questions, demand to talk to the doctor in charge, if you know who the doctor in charge is. I did a study with a medical student years ago where he went and asked people who's in charge of your care, and this was when hospitals were even better than they are now in this regard, and half the people didn't know who it was. It's not like your family doctor comes and takes care of you in the hospital if you're lucky enough to have a family doctor. So have somebody with you who can help you, and it may be easy, the choices may be clear, and they may not be clear. And if they're not clear and you have some time, then that's when you need to talk to people, look inside yourself, and decide when you're ready to throw in the towel. And the other thing I would add is, in the United States, there is no legal ambiguity about your right to refuse any type of life-sustaining treatment, including feeding tubes, ventilators, antibiotics, dialysis. You have an absolute right to do it. We've struggled for 40 years in this country around this issue. It's been in the courts, it's been to the Supreme Court, and there is a constitutional right to refuse treatment, and there's a common law right to refuse treatment. The common law one is the right against battery, unlawful touching of your body. So you have the law on your side. Obviously, if you're in the hospital and you're sick, having a lawyer next to you is probably not possible or a good idea, but you and your proxy need to know that you have that right. Thank you.
Hello, I'm Lisa Vigil-Schattinger, and it's going to take me a minute to figure out how the heck to get where I need to go. I got it.
Wow, okay.
Still waiting, still waiting. Let's see if that little bit. Hey, we're there. So how amazing this is to say some of these things out loud and see your reactions to some of them. So it is a little interesting that now we're jumping right into an issue that in fact is not even legal in Ohio. But here we go. So I really truly thank the organizing committee of the community forum here at the church for inviting me, and for the Cleveland Memorial Society for sponsoring this talk. A lot has changed since the first time I spoke here at the church 3 years ago. Kind of an amazing amount of change has happened, both nationally and a tiny bit in Ohio. For people who've been paying attention to this, which I admit is maybe not everyone the way I do. But I'm here to do this talk, and I really do it to honor my parents. That is Jan and Jack Rowe. Jack Rowe was a retired neurologist, and my mother, Jan Rowe, who still lives in Oregon, is a retired nurse. She's a very long-time hospice volunteer, and she now volunteers for a group called End of Life Choices Oregon, and they help facilitate the process for people who choose this option in Oregon. So she has followed through with her belief in this. I do have objectives that I'm going to skip right over, because this slide is important and quite complicated. The definitions, the terms used when talking about this issue of what's commonly known as death with dignity, there's a lot of different terms out there. And then the concepts behind the terms are important too. So I talk about aid in dying these days. The terms have evolved. You'll hear death with dignity, physician-assisted death, physician aid in dying. Most recently, I will say on a national level, the National Academies of Sciences just hosted a workshop on physician-assisted death. So I think that we are coming to terms with this as a concept on its own. And physician-assisted death is the term that they used in that workshop. That is when a person, Jack, my stepfather, requested the medication from his physician after being diagnosed with a terminal illness and was given 4 to 6 months to live. He requested the medication, he qualified for it under the terms of the law, and then he chose to use the medication to hasten his imminent death. Euthanasia, on the other hand, and there's lots of nuances to this, but in Jack's case, it would have been specifically if his doctor injected him with the medication. Even though he requested it, he went through the process, but the physician specifically injected him with this. That does happen in European countries and in Canada. Canada can do either aid in dying or euthanasia. Then we go to the concept of suicide and assisting suicide. Suicide, is really the concept of a person who is healthy and could live, but due to their circumstances ends up ending their own life. And then assisted suicide, to me, is quite straightforward in that someone assisted that person in dying by suicide, which we want to prevent suicide, absolutely. An interesting example of this is that the academies of, the American Academies of Neurology just put out a statement taking a neutral stance on aid in dying. But they then drew the line saying they do not support their physicians participating in euthanasia. So that seems to be the line being drawn here in the States. So again, a national organization working to prevent suicide in the States has taken this as a stance that they really differentiate these issues. Aid in dying is a different process, it's a different circumstances, different event than those that die by suicide. And their position statement is really well done in really exploring the nuances of this. And any concerns about when those circumstances overlap and when the need for intervention and treatment may be needed. So this was our family, this goes back to the conversation about having those conversations. My family and I spent a lot of time together here in Cleveland in the winter. We had a lot of these conversations. Again, Jack, we were in the medical fields. My poor husband was not, but we talked about end-of-life care and wishes and documentation. It was a part of our conversation. We knew that the death with dignity law existed. We did not know it would affect us personally, but we talked about it over the years. So there was a clear understanding of, or a fairly clear understanding of what our thoughts were about end-of-life care. So Jack, I should go back to Jack. Jack had lived with serious illnesses for a while. He was pretty frail when he did get his diagnosis of bone marrow cancer. And so at that point, he really felt, honestly, he felt empowered. He felt empowered that he had control over his death in the face of his terminal illness. So he went about learning about the law, scheduling the appointments he needed to schedule, and really living his life well, knowing that he was going to be dying. He communicated with all of us very openly about all of this. He made lists of things to do, and he celebrated the end of his life. And we were thankful to be able to surround him with love on the day that he died, on a beautiful sunny day in Southern Oregon with the music playing that he wanted playing, and his death was peaceful, and it was really what he planned. At that point, we decided we needed to share our experience because it is still fairly unique. One of the items on his list was for me to call the insurance company, and when they asked me what his cause of death was, and I said myelodysplastic syndrome, his terminal illness, I realized that I didn't know enough about the law at that point to know if that was the correct answer, his underlying disease. And so I've really been studying how the law works, and the terms of the law, when Oregon developed this law, there was no other state that had it. And so they really paid attention to people's concerns about this, and what were the things that could go wrong with this, and how do they address that through the law. So they put together this law that really has a lot of safeguards that take a while to fulfill, and in fact can be tough to fulfill in the life of a terminally ill person. But they do have to be an adult and a resident of the state with a terminal diagnosis and that prognosis of 6 months or less to live, which is the same qualification used for hospice care. And so at that time, people understood that parameter. It's completely patient-driven, so the person themselves has to make the request twice, separated by 15 days, with a third written request, and then even a waiting period after that before they can get the medication. And they must be mentally capable, both when they make the request and when they take the medication. So that does rule out that concern that some people want to write this in as an advance directive. They have to be counseled on their end-of-life options. They must be able to self-administer the medication. So again, this is not another person acting on them. It's themselves making the decision and carrying it out. And participation is absolutely voluntary by all healthcare workers. So Jack was enrolled in hospice care, and his hospice nurse had said that she would be there if we wanted. We did not feel the need for that, but she could have been there, not to assist, but just to be there with us. And of course, the person may change their mind at any time. They also collected data. They wanted to know what happens with this. Are the concerns that people are expressing being carried out, or what's happening? And they found that over time, in fact, this is a very small percentage of people who've died in Oregon have used this law. The interesting thing is that a third of the people who get the prescription do not use it. Now, whether that's because they just choose, they find that just having understanding that they have that sense of control and they decide not to use it, or if they're no longer capable of using it. I'm going to answer questions in just a moment. And they are people who use this usually have cancer as the largest group, and then followed by neurodegenerative diseases. They are older. They are enrolled in hospice care. So 90% of the people in Oregon are enrolled in hospice care and getting that end-of-life care. And that's about twice the national average for usage for that age group. And then loss of autonomy is the greatest concern rather than pain control. So they feel like their pain and those types of circumstances are controlled. It's the loss of dignity that's the concern. Of course, this is debated, the pros and cons of this. There will always be the concern that physicians should not be involved in hastening a death. And that, everybody has a story of someone who lived much longer than their initial time frame. And this will always be considered morally unacceptable for some. For the pros, out of California, we're really, they're much more vocal about what's happening there. And one of the physicians said that anyone in his health system that he's talked with who's qualified under this law has just simply relaxed. They just are able to deal with the process of living instead of worrying about the process of dying. And they feel comfort in the sense of control. What's happening currently in the United States, there are 5 states currently and the District of Columbia that have a similar law. Montana only has a state court decision, so they don't have those parameters surrounding the law. 10 state medical societies have taken a neutral stance on this. The American Medical Society still opposes it, although they're revisiting their stance. To look for, honestly, I believe in the next 2 weeks that Hawaii will become the 6th state to pass this. And then on the East Coast, New Jersey just passed this out of committee. Massachusetts Medical Society pulled their physicians to change their stance to a neutral stance, so that's going to be interesting to watch what happens there. Maine may be looking at a ballot measure soon. So there is, so the states that are in light orange are the ones who've discussed legislation. So I don't think that this conversation is going away. And in Ohio, we do have a senator who has introduced legislation just in January. It's called Senate Bill 249, and it has been referred to the Health, Human Services, and Medicaid Committee. The goal now is to get a hearing for that. And she's very courageous in saying, it's time that we discuss this in Ohio. It may take a while for this to pass, but we can start the discussion. Interestingly, both Senator Tavares and I have personal experience with losing loved ones to suicide. Her own brother died by suicide. It turns out my own father died by suicide when I was a toddler. And so in our minds, we are clear in that distinction and want to prevent suicide and believe that aid in dying is something we need to have more conversations about. Interestingly now, Ohioans are starting to share their stories. These were both on the Death with Dignity National Center's website, and there are even more people who have shared since this. Pamela Gretatak she is amazing. She and her husband live life to the fullest. She is in constant pain, and she's very active and verbal about wanting this option if her treatment options are no longer effective. Bob Gelatley and his daughter there. Unfortunately, he died in February. I don't know if he knew that this law had been introduced, but he would have been amazed that any conversation was happening in Ohio. So as a group, we strongly support all that we're talking about, all these important conversations, and the need for better understanding of palliative care and hospice care, these important conversations, again, starting at the beginning and documenting all of those. And we do really need your help, so if you feel like you are supportive of this issue, we invite you to get involved. My colleague Molly Graziano will be happy to talk to you. And I always like to leave off with this quote from former governor Peter Shumlin in Vermont signed their legislation not knowing that his own father would end up using the law. But I think his simple statement saying it was a very peaceful and beautiful end to a productive life really closely reflects our experience with my stepfather, Jack. So thank you, and this is why we feel like more conversation needs to be happening in Ohio about this. Thank you so much, and I think we're all going to answer questions now.
Thank you, Lisa. We have 3 rules for questions and answers. Number 1, our microphone holders choose the person asking the question, not the speaker, not me. Keep your questions short, no speeches, please, and hold the microphone very close to your mouth so everyone can hear. Questions?
We have a form here. If you want to learn about upcoming forums and discussions and you're not getting our email reminder, please sign this and you'll be aware of our upcoming forums on some very interesting topics.
I don't know if it's on.
Yeah, it's on, just.
Okay. If you have an insurance policy, how does that work? If you use some form of assisted or whatever, do they not pay you because you killed, did it yourself?
Under the law, it is not considered suicide, and insurance policies are unaffected.
Thank you.
As you pointed out in one of your slides, the thing most of us are fearful of is not dying in pain. It's dying after a few years in a wheelchair with fecal incontinence, not knowing our family when they come to clean us up. And the things that you mentioned seem to exclude any solution for people whose main fear is dying with dementia. How come we're not looking at that? I mean, the prevalence of Alzheimer's is a lot higher than the prevalence of cancer.
Yeah, there's no doubt that there are people who will always oppose a law like this, and yet there's a lot of other concerns that people want addressed in laws like this. I think it goes back to the system of how we create legal precedents as much as the reality of medical concerns at the end of life. In America, this was drawn up by attorneys and lawmakers. And so the states that have this see that the law as written has been effective. And so they're not yet laws passed, as we'll find in Ohio. And so opening up the parameters to those is difficult. And so those concerns, I think, I'm really hoping that they will be addressed by more of a consensus process. There are groups like Compassionate Choices and End of Life Washington that are trying to work on how people are documenting their wishes for those types of circumstances, and the legal process for dementia care. But right now, opening up those parameters in this type of law is difficult. It's difficult to get this law passed at all as it is, and then adding that provision that a person is not mentally capable of making that decision, lawmakers find that tough.
Yeah. So the concern that you raised is high on my list also, I have to say. But this is a very, very sticky problem. And I'll tell you why it's a sticky problem. The Netherlands, which has had a policy of both physician aid in dying and active euthanasia for many years, it's accepted by 90% of the population. The Medical Association has been behind it. And their law is I think, I like it better than the American law because it's suffering that's the issue, not that you have sick. The law in the United States is kind of odd in a way, because all you have to show is that you have 6 months to live or less, and then you qualify. It doesn't say anything about suffering. Whereas the Dutch one is suffering. So you could have 10 years to live, but if you're suffering and there's no prospect of stopping it, you qualify. After the law was there for a while, a legislator introduced an amendment to it, which has been added, which is that you can actually, legally in the Netherlands, have an advance directive that says if you're ever in that situation, you want to be your life ended by a physician. And what's happened is the physicians won't do it. And here's why. I write this now. If I'm ever in the situation that you described, I would like to be my life ended actively. 10 years from now, I'm in that situation. I'm sitting there, stooling in my pants, drooling. I'm not recognizing my family members. And my family member brings the advance directive in and to the doctor and says, okay, could you kill him now? And the doctor they won't do it because the person in front of them doesn't appear to be suffering. They can't tell. And they do it when somebody looks them in the eye and say, this is what I want, but it's very hard for them to do it for people like that. And so one answer to that is to do it early. If you qualify when you're competent to say, I want to do it now to prevent all that, and then you have to say, I'm suffering because I'm thinking about that happening. But that's complicated also. So I'm not sure what the answer to that problem is. Certainly the answer should be, and I've said this to my proxy and in my living will, I don't want any kind of aggressive, I don't want antibiotics, I don't want anything in that situation. I don't want to be artificially fed. But if I'm sitting there and they offer me food and I eat it, it's hard for health professionals to say, well, we're just going to let them starve to death. So it's a conundrum that's in the country that's the most advanced, that's thought about this the most. It's still a problem there that they haven't been able to solve.
I just want to briefly say it would be imbalanced for us to not talk about palliative care right now. So palliative care is not hospice, but hospice is palliative care. Okay, and what that means is palliative care can be integrated with a patient and a family at the point of any serious illness. And that team of providers follows that patient and family over the trajectory of their illness. This is concurrent with life-prolonging care. That's not the case with hospice, where we typically do not support life-prolonging treatments and interventions. So for the gentleman who just asked this question, I hear what you're saying, and I very much support both sides of this, but we never want to forget that we have experts who have been expertly trained in hospice and palliative care to help work through issues of suffering and intractable pain, psychologically and physically.
I hope this is an easy question. Lisa, on your map, I'm here. On your map, Montana was a different color than every other state. What's happening in Montana?
They have a state Supreme Court decision allowing physicians to write if a patient requests, but they don't have an actual law with any of those safeguards. So, yes. Yeah, but they don't collect data either. So Montana's out there. It's happening. We don't know a lot about it as far as I know. I haven't studied it simply because it doesn't have a lot of parameters.
I have two observations. But first I want to say what a privilege it is to be able to share in such a professional level discussion of a subject that terrifies most of us, and to be able to do this in an atmosphere of rationality that is not dominated by supernatural fears and so on. So this is very valuable for me. Yeah. And the second is directed to Ms. Schettinger, Lisa. In Oregon, after going through the procedure, you can come up with a deadly potion in your hand. like a hemlock, but you've got a deadly potion in your hand, and only 1/3 of the people use them. Do the other?
A third of people don't use it.
Do the other people? Do you have to give that back, or?
It is a good question. It is a good question. Yeah.
Write a little murder.
Yeah.
Or I get this and I sell it, or whatever.
So that is, there's two parts to this. The part I can address is that that has kind of evolved in the states that introduce the laws now, and they say that if it's not used, then you do have to dispose of those drugs according to the state, plans for that.
I don't get around that.
Well, you can talk about hospice, and sort of all the medications that are available. So yes, they do try and address that in saying that, there's a time frame in which the medication has to be disposed of properly.
I want to just add, how much do you pay for that medicine? How much do you pay?
When my stepfather used this, it started out as a very cheap drug, generic drug. When my stepfather used it, it was about $1,800. Now it's upwards of $3,000, and that is because of the company Valiant, I think it is, that they're seeing this as an opportunity, and they're capitalizing on it, and so that's leading to a whole other process of having to develop different formularies for it. So.
Simple hemlock still work?
Simple hemlock, is that available at a compounding pharmacy? I don't know. So, we want to have systems that are the best practices for this, right? We want it to be effective as the way it's written.
Hi, me. Okay, my 55-year-old stepbrother was terminally ill, and he was told he had to go in a nursing home, and he shot himself in the head with a gun on his front porch. And he lived in a state where there was no kind of help or anything available. I think the nursing home for him represented a total loss of dignity and control. But are there a lot of people who commit suicide? Because I guess that's what he did. He had COPD, so he may have had more than 6 months. Though it was terminal, but are there a lot of people who commit suicide, or are there any stats now from people being terminally ill?
Yes. The answer is yes, but not in the United States. There's a psychiatrist in the Netherlands his name is Shabat, and he took one of the first cases that was tried by the Supreme Court in the Netherlands was his patient. And he stayed very active in this area. And when he was 70, he went back, he wanted to do a study of just this issue. So he went back and got a PhD in health services research. And then he did a study in the Netherlands that's never been done anyplace else, looking at that issue. And he found out that large numbers of people were doing just that. Not necessarily with a gun, that sometimes there was people who were turned down for euthanasia. And he in his research, he excluded people who were committed suicide because they were depressed. It wasn't the usual. These were people in the context of a terminal illness or an illness that was making them suffer, found a way to do it with the help of other people, or they don't have as many guns in the Netherlands, so it's harder to do it that way. But the study is very interesting, and there's no reason to believe that the figures are any lower in other countries. So it probably goes on to a fair extent.
I will say that there are physicians involved with this through Compassionate Choices and other medical directors in states with these laws, and they said that specifically they got into this issue because they had patients who ended their life by suicide, and it was so traumatic for everybody that they thought there has to be a gentler way to do this.
Should I go ahead? Okay. Yeah, it kind of dovetailing with what was asked a moment ago. There's only 5 and maybe going to be 7 or so states that have these kinds of laws. So what about
people who live in the rest of the states? I mean,
what
options are there? I mean, I'm sure there's ways.
You have to get involved. You have to get informed on what this issue is. You have to talk to your legislators. We have to go through the process.
That sounds very reasonable and something to do, but it also sounds a bit long-term for...
It's long-term.
You know, for people who live in states where they're...
So there's a group, what is their name? Is it Final Exit Network?
Hemlock Society?
Final Exit, I love it.
The Hemlock Society?
Well, it used to be the Hemlock Society, and now it's called, I think is it the Final Exit Network? And they, I'm sure they have a chapter in Ohio, they will give people, and they figured out how to do this in every state without getting in trouble, because physician-assisted death or just lay people helping other people commit suicide is against the law. But they figured out a way how to tell them how to do it without getting them in trouble and without getting your family members in trouble. And Lisa has obviously a negative view of them. I don't know them much at all, but they're out there. And I have to say, this is a problem that I've worried about for myself. Okay, the time comes and if I lived in Oregon, I do it. What about here? What am I going to do? And it's an issue. It is a real issue.
Back here. Hi. Hi. I want to address just a couple of things, in reference to what Stuart said. Yes, there is. Oh, hi. I'm Molly Graziano. I'm one of Lisa's volunteer co-workers, and I go around the state of Ohio and talk to people about this issue. And I've been a longtime supporter of this issue. I've taken care of both of my parents in the home who died of terminal illnesses. And I spent 10 years working in organ and tissue donation. And I think, our concern with Final Exit Network is that technically the methods that they are using are considered illegal. So what we are really looking to do here in the state of Ohio is to come up with a law with those safeguards built in. And I will tell you, anecdotally, people think, oh, it's going to take a long time, it's going to take a long time. And, it's going to go through the legislature, so of course there's going to be a process. But when this bill was introduced, we did a lot of study of the comments and things that were coming out, through social media and in articles. And I think you would be rather surprised. There is a very strong group of Ohioans who really feel that this needs to be an option. And if we are going to get this law in Ohio, we're going to get it quicker if the constituents say to their representatives, you represent me and this is what I want. So that's really what we're trying to do, is to get that grassroots effort, get your voices heard down in Columbus so that we can move this through. Because in the other states where the law has passed, it has been a bipartisan effort. And in one of the slides that I work with, it said that 60% of people who identify as conservative believe that people should have this option. So this is not really necessarily a partisan issue. When you sit down, it's a very personal issue. So I'm maybe a little bit more of a cockeyed optimist in thinking, is it going to be a challenge? Sure, it's going to be a challenge, but I don't think it's going to be as long as it needs to be. It's going to take as long if we get the voice of Ohioans down to Columbus so that your representatives know what your opinions are.
I'd like to know if there are any efforts being made in the medical community to change the diagnosis of dementia or Alzheimer's to one that is called a terminal illness. There's not one physician who could ever say to any of the people I've known with this illness, oh yeah, we'll be able to help you with this. It's a terminal illness, there's no question.
Well, what do you mean by terminal illness?
Well, it's not designated a terminal illness.
That is a terminal illness. I would argue it's not a terminal illness.
Well, they're going to have to change, I guess, the expectation of time for this terminal
the parameters.
Yeah, given the parameters now, which is, well, we don't know how long someone could live.
And there's so many different types of dementia, right? And each type really displays itself differently based on the characterizations of the patient. We do have some parameters. The National Hospice and Palliative Care Organization outlines those based on research we've done. So one of those is that they've lost all function of independence. They're bedbound, they speak less than 6 intelligible words, and they're not able to toilet themselves. Now, even with that, we get them in, right? And we get them enrolled in a hospice level of care, and we're giving them a team approach. So that means, you know, nursing, social work, spiritual counseling, physician, you know, medical. Here's what happens. These folks end up doing better and living longer. And by the hospice Medicare benefit, just like with heart failure, for example, or COPD, because they're being taken care of as a whole person, not just an isolated piece of a person, they do better, live longer, and CMS, Medicare says, you have to discharge them. So then they go back into the system of what do we do? So we have a really convoluted, complicated healthcare system with these parameters. I know that did not answer your question at all, but it is the reality. And that's very difficult for us, where we've been working with a patient and family for 6 months, and suddenly we don't see them declining or deteriorating as we need to document for CMS, and we have to discharge them by law. That wasn't a good answer, but it's the reality.
There isn't a consideration of finances in our discussion, but we've had relatives who've been in nursing homes, and nursing homes are $10,000 and $15,000 a month, plus one that I looked into recently was $25,000 first a payment and then $15,000 a month. If somebody's lingering, you can't say this can ruin the family. The family's wealthy enough to have some of this money, but it's a real consideration. And Alzheimer's, I've had 2 relatives in Alzheimer's units. You go in there, you can't imagine that we shouldn't have euthanasia. They're out of their minds. It's just horrible.
They're drugged and they're sitting around. Right?
Yes. They can't talk. Many of them, it's just pathetic. But the financial part, until you're up against it, you aren't aware of it. And now that I've been checking it, I'm aware of it. It's very scary.
Thank you for your comment. I don't think there's any one of us up here who would not agree with you. There are just no solid answers to be able to respond to that in a meaningful way, other than we have to start the conversation. We have to begin to talk about it as a society. Huge financial burdens.
Sorry, a completely different issue within that is that some people who move to continuum of care communities, you know, where maybe there's independent living, assisted living, skilled nursing, it's very complicated even within those settings. So, you know, you think that your answer, you've got the answer to your question when you move in, and in fact, it just gets more complicated. So having these discussions is just, it's the only way we're ever going to move forward.
So I'm a physician, and I happened to witness an event this week. This was approximately a 50-year-old man who had cerebral palsy and mental retardation, and he lived with his family. And he had had several episodes of pneumonia related to improper swallowing. And he had a severe bed sore that he was getting antibiotics for, and he was referred to get a feeding tube. And he had the feeding tube, and as he arrived for the feeding tube, I mean, he was screaming like many people with severe cognitive impairment do, for no real reason. And all I could think of is that this guy shouldn't be getting a feeding tube. But his family who lived with him, and this young man could live, he's 50, he could live many more years. Could you talk a little bit about decision-making in those circumstances where the person is retarded and decisions throughout his life, basically?
Well, what would the alternative be to what happened? It would be somebody told the family that you can't do that. And imagine what kind of law would say that people, when they're retarded, which is a word that is not, what's the correct word now? Developmentally disabled. There's people who are developmentally disabled have organizations that are very, very concerned, because those people are a very vulnerable part of the population. So it would be, I know this isn't what you're talking about, but on what they would say is society would like to get rid of people like us. And I think that what you'd have to do here is go against the family who wants to keep him alive. And that would be a pretty tall order in our society to start doing that. I think that, I mean, sitting here listening to this, I think one of the things that's going to happen, you know the story about the Gordian Knot? So Alexander the Great, there was this knot that people said if you could untie it, you'd rule the world, and nobody could untie it. He came in and he cut it with his sword. Something's going to happen to deal with this stuff because of the economic burden. And not just the economic burden, but the social burden on caregivers, that it breaks their backs. And it's a growing problem. It's not a diminishing problem. Something's going to happen. And my own thought is it's probably not something we would like, but it's going to happen.
I would just like to really quickly respond to this, and I've had a lot of situations very similar to this in terms of having family meetings over time. My hope for this family is that it was a medically informed and educated decision. This is not something that happened overnight. Clearly, they have been caring for this child, and obviously adult, for a very long time. As a healthcare community, we should know what that relationship is. We should know what they value, what they believe in. What I would want from them is, what is a meaningful life for this man? Then providing them with the evidence that we know about medical intervention, specifically feeding tubes. This is Joan Tino's work out of Brown University. And in light of the fact that he also had a skin tear, skin breakdown, I would present that information to them in a very compassionate way, letting them know that actually what this intervention would be doing is providing more harm than good. And what we could expect is his mortality rate would actually be increased by doing this. At that point, once I give them that information and we take time to think about it, we also, as a medical team, have the right to say, we will not do this to him because it will cause more harm than good. At that point, the family has the right to go somewhere else to have that done. So that's not just an event that happens, that's a conversation in a process that takes time in order for that to happen. And I so hope that did, and I don't know, but I wanted to at least offer that.
It's 10:40, we have time for one more question.
I just wonder if Lisa would expand on what way it gets more complicated if you're in continuing care.
Oh gosh, we could have a whole other forum on that. I had mentioned how it gets more complicated sometimes when one moves to a continuum of care community. My grandmother is the perfect example. She moved into an independent living apartment on one of those communities. She fell and then required more care. She did not want to be in the community in the first place, but I was a long-distance caregiver, so we wanted to maintain her safety. How did we move her to the assisted living? Who did we talk to? What was the time frame? So she fell, she had surgery. We had to get people, boots on the ground, there to help her move within a certain amount of time. She was in the assisted living facility and fell, and her dementia progressed as a process of that. She needed more care. How did we get her to the skilled? Now, of course, they have social workers and they do have systems in place to help manage those transitions, but we didn't know what they were, and I was calling from Ohio. So, you know, I would fly into town and say, I want to help grandma, who do I talk to? And are they there that day? And do they have her chart? And so you need this bodyguard. You need to be the person, have a person saying, who do I ask these questions of? How do we help facilitate these changes? And it can be very difficult. Sorry, I hate to end it on that note.
Well, I thank the entire panel. Certain announcements today. Our next forum actually is going to be held in 3 weeks on April 15th. It's entitled Community Engagement via Art. Cleveland Institute of Music President Paul Hogel will be the speaker. The topic, what does the future hold for excellence in local arts engagement? With 400 students and 1,000 in preparatory and continuing education programs, Cleveland Institute of Music is known for their innovative music programs, digital engagement, and nearly 600 free concerts per year. You are all invited to this morning's church service upstairs at 11 o'clock. Honey Bell Bay is our guest speaker at church today. You may recognize Honey Bell Bay's name as the founder and director of the group Distinguished Gentlemen of Spoken Word, which received an outpouring of Clevelanders' support to enable them to perform in Paris several years ago. She has won numerous awards and congressional recognitions for her innovative programming strategies engaging youth from high-risk environments. Grounding Honey Bell Bay's life and work is deep spirituality and awareness of the human potential. We are incredibly honored to have her as our guest speaker next Sunday, along with one of our teenage performers next Sunday being today. Thank our panel again.